know, if you call technology service,
being recorded.
they always say, well, did you turn it off and restart?
Restart.
Yeah.
Yes, that's our one great technological tool.
If all else fails, restart.
That's right.
It usually works.
Too bad I can't do that for life. All right, well, it's 8:30. Good morning, all of you sports fans. We'll get the meeting started. I'm calling the meeting to order. And Mr. Ryan, if you will introduce guests and staff, I'd appreciate it.
Okay. All right, we'll do roll call first. So Commissioner Anderson.
Here.
Commissioner McKinney.
Present.
Commissioner Lindy.
Here, good morning.
Councilmember Byers.
She's rebooting.
Okay, we'll go back to her. Dr. Atterbury.
Here.
Commissioner or Councilmember Duval.
Present.
Dr. Cleary.
Here.
Stephanie Algren.
Here.
Aileen Ackerman.
Here.
And Yakima Health District staff, Andre Fresco.
Here, good morning.
All right, myself, Ryan Eibach, Chase Porter.
Here.
Melissa Sixberry.
Here.
Lillian Bravo.
Joining now, Ryan.
All right. Sean McGee.
Good morning, here.
Nathan Johnson.
Here.
Dr. Bard.
Sorry, here.
Lillian Bravo.
Here.
Jocelyn Castillo. Jocelyn. No.
Here.
All right. Victoria Reyes.
Here.
Andy Wilson.
Here.
Leslie Gonzalez. Leslie Gonzalez. All right, James Elliott.
Good morning.
All right, we'll go back to board members, Patricia, Councilmember Byers,
Present, thank you.
and Jim Curtis. Okay, and we do have two new staff members to introduce. So we'll first go with Sean McGee. We'll introduce new staff member, and then Melissa.
All right.
Morning, thank you. Yeah, joining us today is Andy Wilson. He's our new environmental health specialist here at the Health District. So Andy, do you want to tell us a little bit about yourself?
Excuse me. My name is Andy Wilson. Grew up here in Yakima County in Natchez. Went to school at Central. I worked at Department of Corrections for Yakima County for 7 years after school, and then I did about 8 years at Department of Ecology with the Hazardous Waste Inspection Program and the Spill Response Program.
Well, your Department of Corrections training is very good fit for the health district. They're a wild group.
And he's not the first person actually that we've hired from corrections. Interestingly.
All right, thank you.
All right.
All right.
And Melissa.
Anyone else?
Yeah, so I'd like to introduce Leslie Gonzalez. She's one of our new public health specialists. If you want to just do a little background on yourself, Leslie.
I'm Leslie Gonzalez. I grew up in Toppenish, so I went to Toppenish. I got my bachelor's in medical laboratory science, and then I worked, and I'm also certified as a medical laboratory science, so I have my certification in that. And I worked 2 years in the laboratory in Memorial.
Good.
Now I'm currently in my master's program for public health, and I love it so far here. So everyone's really nice.
Good. Welcome, both of you. Mr. Eibach, is there any written comments from the public?
There are no public written comments submitted.
Thank you. We'll next go on to consent agenda. The following motions will be, all items will be listed with an asterisk, are considered routine by the health board and will be enacted in one motion. I would entertain a motion.
I move to approve the consent agenda.
I'll second. This is Patricia Byers.
Been moved and seconded. Any discussion? Hearing none. All those in favor?
Aye.
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 Hi.
Aye.
Aye.
Any
Aye.
opposed? Oh, I'm sorry.
Aye.
Any opposed? Hearing none, motion passes. Thank you. We will now move on to number 5, the Yakima Health District Spotlight. And Melissa.
Hey. Pull it up. Thank you, Jocelyn. So this month's spotlight is on YHD's harm reduction program. I'm sure we'll have great discussion and comments and questions, but I just ask that we'll hold all of those until the end. Next slide. So what is harm reduction? It can be defined as a set of practical public health strategies designed to reduce consequences of drug use and promote healthy individual lifestyles and communities. One thing you'll often hear in anybody who works in harm reduction is you are literally and figuratively meeting these individuals where they are. So we recognize that the best way to reduce the negative consequences of drug use is to obviously not use, but for some people, whether they're unwilling, unable, et cetera, for whatever reason, our intervention and public health strategies is to reduce those negative consequences of their drug use until they are able to reach recovery at some point in their life, hopefully. Next slide. So syringe service programs, one of the main things syringe service programs do is prevent disease. And we do this through a harm reduction interventions. You can see on the left here that in the United States in 2019, there were over 36,000 new HIV cases reported in the United States. And it's estimated that there's over 57,000 new hepatitis C infections every year. And there's also other infectious diseases that are related to injection drug use, including hepatitis B, MRSA infections, botulism. So one of the things that we do in the harm reduction model is you have someone who's using a contaminated needle because they don't have access to sterile syringes. They put themselves at risk for HIV, hepatitis C, HPV is hepatitis B. And so the harm reduction public health strategy is to provide a new sterile injection for every use for those individuals in order to prevent further spread of these viruses. Something that a lot of people don't think about is contaminated water. Many of these people are homeless. They don't have access to clean water. And so they are literally taking water out of a toilet or out of the river. And they're using this to inject their drugs, which harbors bacteria, fungal funguses, and other pathogens. And so we do provide sterile water to these individuals because, again, these can lead to infections that cause sepsis in an individual, which could lead to hospitalization, could lead to death, etc. So all of these interventions are what we define as harm reduction. We are reducing the negative consequences of the action of the individual that's using drugs. Next slide. Look at how we reduce the negative consequences of drug use by looking at how the financial consequences of someone who uses drug use. So it's costing the healthcare system $15 billion a year to take care of chronic hepatitis C cases in the United States, $700 million to take care of substance use related infections in the United States. And the average cost to treat somebody for their lifetime of HIV treatment is $450,000. These are all numbers that came from the CDC. And you can see that on the bottom, that very small number of under $79,000 is what it costs to run YHD's syringe service program in full operation. That means providing all of our services at needle exchange, our syringe service program. And remember that number 450,000, because I'm going to give you an example here on the next slide, please. A scenario that actually happened in Scott County, Indiana. Between November of 2014 and November of 2015, the CDC identified 183 HIV cases that were related to an injection drug use outbreak. There was a study done, and what they found that there had been public health measures in place prior to this outbreak that many of these cases could have been prevented. And so by using a modeling, they found that if there had been interventions, meaning a syringe service program, in place on January of 2013, they could have kept this outbreak to 56 or fewer cases. If they had interventions in place going back to April of 2011, they would have kept this down to 10 or fewer cases. So by taking 183 cases that came out of this outbreak and $450,000 to treat an individual over their lifetime for HIV, that's $82 million that is correlated to this outbreak alone. Next slide. Look at harm reduction and how it spreads to the community. A lot of people think if you're not involved in the drug using population that you don't have to worry about these viruses, but here's an example of how some of these viruses can easily transmit to the general community. HIV is hepatitis A virus, which is spread through fecal to oral route. This is a true case where we had a hepatitis A outbreak in our homeless and drug using population. One of these individuals happened to be a food handler in a restaurant who we were able to identify an exposure, not an exposure, but a risk to the public because of the food handling, using the bathrooms within that facility. And that's how it can easily spread from a drug using population to the rest of the community. So in harm reduction, we provide services to help reduce that spread to the rest of the community by, in this particular situation, we went out and we administered Hep A vaccines to the and our needle syringe service program to decrease further spread of Hep A. We also provided hand hygiene supplies to encourage hand hygiene out there, and we educated them that this outbreak was going on, to educate their community and what they could do to help themselves and prevent further spread. Next slide. So for many people in the drug using population, they are resistant to access healthcare or other services because of the stigma. They fear going into the emergency room, that they're going to be considered essentially just drug seeking. And so many won't seek care for anything. A lot of times our SSP is the entry point for them. We are the only resource they have to get services other than, syringe services, but including things like medical care, vaccines, wound care, etc. And so we also know that SSPs save lives, and people who use one are 5 times more likely to stop injecting drugs than those who don't use them. It also protects our law enforcement officers and our first responders by reducing needle stick injuries of contaminated needles. We reduce crime. We know that drug users are going to get their drug injection supplies one way or another, and if they don't have easy access to them, they will steal from medical care facilities, they will steal from diabetics, they will steal their insulin needles. So it actually reduces crime. SSCs also promote safe syringe disposal. We're educating these people to bring them back to our syringe service program in efforts to keep these needles off of our streets, out of our schools, out of our playgrounds, to have our community healthy. SSPs are cost effective, which I just spoke about in the Indiana, Scott County, Indiana situation, and also the cost of HIV, Hep C, and infections. And then they also reduce the healthcare costs to our local hospitals by reducing the number of wound care infections, the number of HIV or hepatitis C or other communicable diseases. We're keeping these out of our ERs and reducing the burden on the healthcare system by keeping them by keeping the communicable disease down. Next slide. So syringe service programs, and what all do they include? All syringe service programs will provide sterile injection supplies and safe disposal. However, most have progressed to include other harm reduction strategies such as critical services, linkage to care, and referral services. And again, remember that SSP, or the syringe service program, is really just the vehicle that allows us to provide harm reduction strategies to a population. Next slide. And so how did it all start? History of SSPs in Washington State. Tacoma Pierce County, there was a man by the name of Burgess. He used private funds to get up and running the first SSP in the state, and he did this in response to an HIV epidemic that was having an impact on people who inject drugs, which is the PWID. And that was back in 1988. Next slide. Slide shows, if you look back to the far left there, where our numbers were at for people who inject drugs going back to 1990, you can see how after syringe service programs were implemented in 1988 was Tacoma Pierce, in 1992 was the Spokane syringe exchange program implemented, and you can see how these trends started to go down. So it shows a correlation on the impact of having a syringe service program and decreasing the number of HIV in people who inject drugs. Next slide. We're not the only SSP. So this is a current, these dots each represent areas that have a syringe service program. There's 29 of them currently, 17 are through local health jurisdictions, 8 are through community-based organizations, 1 through a federally qualified health center, and 3 of them are through tribal. Next slide. And I'll also say that some of them are privately funded and some are funded by the state. There's several different funding sources. So here's a little history on YHD's SSP. It was established in 1993. It was actually the 3rd one in the state, right behind Tacoma Pierce and Spokane County. And it started with just a 1-for-1 needle exchange only. That was the only service that was offered out there. Because really they were reacting to an HIV epidemic so at that time it was simply just a response of just 1-for-1 needle exchange. And we have never had a break in service since the implementation, regardless of funding. Even through COVID, we found it very necessary to continue the syringe exchange in order to prevent something from occurring like an HIV or Hep C outbreak, such as the one in Scott County, Indiana. So here's some of our funding sources. We receive a grant from the Department of Ecology that allows us to provide education for proper disposal to our clients. That's $4,800 a year. We also receive funds from the Washington State Department of Health. We receive $48,000 in salaries and benefits, supplies $26,000, which includes things such as the sterile water, hand hygiene supplies, and our syringes, etc. And that totals the $78,800. It's ran on a 0.7 FTE and it's staffed with our public health technicians and public health specialists who are all trained up to provide education and also proper technique on how to handle syringes. Next slide. So Yakima Health District, we work on a 1-for-1 needle exchange. And again, this is all based on the harm reduction. We provide a 1-for-1 needle exchange because we're encouraging the return of used syringes, because the idea is that we're going to help prevent further spread. We don't want these left on the street. There are some that use what we call a needs-based syringe. So if somebody comes in and asks for 100 needles, they can get 100 needles without returning any. But we've always operated on a 1-for-1 in order to encourage the return. We also provide education. We teach them how to safely dispose of their needles and encourage them to bring them back to our site rather than leaving them on the streets or in parks. We educate them on safer injection practice, meaning don't use contaminated needles, don't reuse needles. And we educate them on communicable diseases. So if we know that they're going around such as that's affecting their community, we do educate them. Well, we've had botulism from black tar heroin. We've had, the Hepatitis A. We were able to reach a community that no one has access to, that we could provide direct education to them and educate them. So, and we also provide safe sex practices. We encourage condom use. We help decrease the number of STIs in our community. We provide naloxone and Narcan distribution and training, so we prevent and reverse overdoses by doing that. Another harm reduction strategy we have out there to decrease Hep C, HIV, and syphilis is we do screening out there with referrals for treatment for positive cases. And we also administer vaccines to help decrease our Hep A, flu, and COVID within our community. Those are vaccines that we administer out there. Next slide. More services. We also have basic wound care. So if somebody has an infected wound from an injection site, we have a resident physician from Central Washington Community Health that can go that provides basic wound care. They can do drainage on an infected wound. This provides an educational experience for future local providers and a great partnership with them. And by providing this basic wound care on our syringe service program, we are preventing additional ER visits, which is putting a burden on our already stressed healthcare system. Patient navigation. So 2 of our public health specialists, Leslie being one of our new ones, and also Edith, provide case management. So we provide referrals when these people are ready. We would develop a rapport with them each week while we're out there. When individuals are ready and want treatment, we can refer them over to Comprehensive Neighborhood Health or any of the partnerships that we've developed to get them the drug treatment that they need and want. They also get them case management for their chronic disease management, whether that's blood pressure or maybe they're a diabetic. We help them get some stable housing. We help them get food and mental and behavioral health. And these are all referral processes that we have in place. And part of management would also be too, if someone is Hep C positive, we can get them linked in because there is a cure for Hep C. So we get them linked in for services and follow up and make sure that they get their treatment completed. Next slide. So here's a survey. We always like to evaluate our programs. And so here's a survey that we did on our syringe service clients. 72% reported taking back improperly disposed syringes, which is needles that they found on the street or that were otherwise improperly disposed of. They will actually pick those up and bring them back because they see value in them and they know that they can get a sterile syringe if they bring that back. 98% state that the needle exchange has taught them to dispose of needles properly. And 79% of them state that they think others would improperly dispose of needles if they didn't have our syringe service program. But so this graph shows that there's actually a minimal difference between needles in and needles out. The yellow represents syringes out, the blue is syringes in. So it shows that our clients really are returning their used needles and they're not leaving them on the streets and the parks and the playgrounds, which is helping keep our communities safer for us and our kids to be able to use our parks and enjoy our community. Next slide. Some of the successes that we've had through our harm reduction program. By having a hepatitis A outbreak in 2019, our harm reduction intervention was to administer vaccines, and we were able to administer 33 vaccines out there, which might seem like a small number, but for those that are 30 and under, they likely have had Hep A vaccines in the past. So these are people who were already who were unvaccinated at the time of the encounter. In 2019, we identified 28 positive hepatitis cases that we screened and referred for treatment to the local liver clinic in partnership that we created. In 2020 to 2021, we had a reported 206 overdose reversals documented. Those are documented of Narcan that was distributed from our syringe service program. We had administered for the 2020-2021 flu season, we administered 40 flu vaccines. And we served almost 3,000 clients in 2021. And those are duplicate clients, so those are encounters. And we exchanged almost 236,000 needles. And we completed 11 referrals for treatment to comprehensive healthcare through a partnership with their hub and spoke model for treatment, which 11 may seem like a small number, but we are talking again about a drug population who is injecting drugs who have likely been using for many, many years. And it's the toughest people to get sober. And so 11 completed referrals is actually a pretty rewarding number that we're very proud of. Next slide. We worked with our coroner's office and we also ran some numbers and we looked and we identified that Toppenish actually had higher incident rates of HIV and overdoses. So we identified that there is a need down there for our services. And so we, in 2019, reached out to Toppenish city officials, to community members, business owners, etc. And we presented to the city council our interest in expanding our syringe service program to their community. And in March of 2019, these are the meeting notes, and you can see that it actually passed on a 5-to-1 vote. Unfortunately, the location that we had chosen, the business owner decided to sell Then we went immediately into a Hep A outbreak and immediately into COVID, but definitely something that we recognize is still a need within our community. Next slide. So how does this align with our strategic goals of Yakima Health District? The syringe service program is not a mandated service. However, controlling communicable disease is, and by controlling community and fighting communicable diseases, it is actually helping us to deliver that mandated service. Develop a network of community partners invested in improving health. We built partnerships such as Central Washington Community Health, Comprehensive, Yakima Neighborhood Health, local law enforcement, city council, city officials, and then increasing the effectiveness and efficiency of our district services. Remember, we recently just purchased a new motorhome that gives us a mobile platform to be more efficient and effective in our services and hopefully reaching populations that we haven't been able to reach yet. And with that, I'll leave it up to any questions.
Anyone have any questions?
I have some questions, if I may.
Sure.
Okay, so first of all, thank you for this because it's pretty thorough and answer a lot of questions I had to begin with. So I want to say that, looking at how the program operates, I think it's not only compassionate for those people who are addicted, but it also extends some compassion toward other people in the community who might be exposed to things that they experience because of their needle use. I do have a question about, one of my questions is that a one-on-one exchange, and you said in the presentation it is, but then you talked about a bundle of 100 needles. Is that 100 needles in exchange for 100, or is it just?
So that's actually because we operate on a 1-for-1. There are many syringe service programs that operate on what they call a needs-based. And so my example was that if somebody came in and asked for 100 needles, they would get 100 needles and they didn't have to do anything in exchange. We've never chosen that philosophy, and we believe that by doing a 1-for-1, meaning if somebody brings in 100 clean needles, we can give, or dirty needles, we can give them 100 and clean, but they have to bring those needles back to us. And so we're encouraging them to keep them off the streets, bring them back, and not just leave them, wherever they may be.
Okay, so it is truly a 1-for-1 then.
It
Is
is a
my
1-for-1.
okay. So
If
my
I
next
may,
question,
I'm
yeah, I
sorry.
have a few questions if you don't mind. My next question is, you're talking about giving them clean water, sanitary water. Is that like one little sack for a needle, or how does that work?
It's just a little plastic container that holds maybe a milliliter or 2 milliliters of sterile water.
Okay, and I was glad to see the response that so many of them are turning the needles in. One of the greatest complaints I hear from the business community is that they find so many needles still out in the streets. So I was interested in the education piece. And when you educate them to bring the needles back in, are you giving them a biohazard container that they can use to bring those in?
We do. We have biohazards for anyone that chooses. Some will just keep them in their backpack, but we certainly encourage them to keep them in a sharps container to protect, obviously, our law enforcement, our first responders who may encounter them, and we have to provide those. That would be considered part of the supply of that $26,000. That is something that we use as for our sharps
containers. Okay, great. Thank you very much.
And
Thank
if
you,
I'm-
Dr. Atterbury, then Daleen, and then Commissioner Lindy.
First question, do we have any idea what percentage of all needles used this program represents? In other words, is this 5%, 1%, 50%? Is there any metric you have on the amount of needles being used in Yakima County?
In the one slide I showed that for 2021, we exchanged 236,000 needles. I don't know if that answers the question.
Right. Do we have any idea on the denominator, though, of how big the problem is?
Compared to other counties?
In Yakima County?
I guess I'm not understanding the question.
Well,
What percentage of those 200 and some thousand are, is it 1,500,000, or what's the percentage of that?
How they were distributed?
Well,
of the needles being used in the county, I guess is my question.
Oh, yeah, I don't have that number. I mean, I know we do have other syringe programs in surrounding counties, including Hepatitis and Benton Franklin, but most of these individuals aren't able to travel those distances. So I imagine this is all mostly just local exchange needles.
yes, Dr. Atterbury, I'm sure there are others who are using who are not returning them. But one thing that I did want to share is that if you spend time at the harm reduction site, you'll see people coming in from all walks of life, walking in, biking, catching a ride, driving a car. We have people with many different who are working and actively employed in our community. So people are very familiar with the program. And so we've created a value to those used needles. So there is a benefit for people to come. And we, again, it's a welcoming space, but we do encourage the retrieval of those, because we are very concerned about, as we've talked about, having needles on the street, having children learn about intravenous drug use. But I did want to add, if you don't mind, Melissa, that once we receive those needles that are dirty, we keep them in safe disposal, and then we package them, and then our environmental health team takes them to our recycling, or rather our solid waste disposal, because it's really about environmental stewardship as well. So it's a beginning, middle, and an end process for us, where we want to make certain that there are no problems. So we value the program, the members value the program. They bring us those dirty needles, and then we dispose of them properly. Thank you.
A second question to fold into that. You mentioned referral for hepatitis C treatment and potentially also HIV treatment. Does the county or the state cover the costs associated with the treatment itself? So I know the hepatitis C drugs are rather expensive, as are the HIV cocktails. Are we doing anything once we refer them onto treatment to make certain that they actually receive the treatment and it's not a blind end referral?
Yeah, so part of that was a lack of funding. We've recently received a new grant, which is where our new public health specialists are coming in that can actually do the case management piece to ensure that they don't have any barriers to get their treatment, or low barriers. When we've done surveys, most of our syringe service clients are covered by Medicaid. And we know that that also is a tax burden for the rest of us. And so we know that that's part of the cost effectiveness, is if we can prevent some of these HIV or Hep C cases, then we are actually reducing the tax dollars being spent for long-term treatment. But we do link them into the liver clinic, and if they have Medicaid, that will pay for their treatment. And most of them do.
Thank you. Nice presentation.
Thank you.
Daleen.
Oh, yeah. Thank you for your presentation. There's a couple of things that stood out to me that seem a little bit misleading. Do you have any statistics? So the first one was about the costs comparisons. And so you compared the cost, like our local cost, to like national burden of, taking care of the diseases. So that seems a little misleading, because it's giving these drastic differences. But is there any information for like what are our local costs of, treating people for the diseases compared to the cost of the program?
I think it would actually be hard to show the benefits, because by actually having an SSP, we are preventing these diseases from occurring. We've had a major reduction in our active or acute hepatitis C cases. So I think you would have to look at what it would look like to not have a program and compare it to having a program to actually really see the cost benefit. So the example was given for a county who did not have one, and what that could have looked like if we didn't have one and had an outbreak.
Yeah, so we don't have any local, like, okay, it cost us this much to treat HIV cases and hepatitis C cases, because I think those were the examples in that slide but it was national. So it looks like this huge difference when it probably isn't locally. And on that case study, are there any examples from communities of actual reductions? Because those were speculations, like it could have been reduced, but is there any communities that have said we've actually reduced it by this much?
There's a lot of research out there, peer-reviewed literature that will support syringe service programs and the cost effectiveness of them. This is just one that's a highly known case that happened here in the United States.
And Ms. Ackerman, we could share, we can gather some of that research if you'd like and just send it out. But I would share one of the things that often goes undiscussed with these programs is the cost to what is often referred to as indigent care at hospitals. If someone, as an example, becomes sick because of an injection site that's been infected, and then they have full sepsis in their body, and they go to get care at the hospital, if they don't have health insurance or are covered in any way, often those people will receive the care and then they leave and are not required to pay, which then becomes a cost burden to the hospital, given the fact that we are a rural community that already had really health professional shortages already. And now with the closure of regional, we've committed to the idea that by prevention, we actually lessen the cost of healthcare in our local area.
Right. Yeah, I understand that. I guess maybe it doesn't, in that examples, even for the national cost, it doesn't really get into the specifications of the breakdown of those costs and how is that to the taxpayers for the people that aren't paying, or is that just the overall cost no matter who's paying? But I don't know, so some of those things can be important when you're looking at a justification for programs and, comparing apples to apples, it would seem. And then on the example of like with the hepatitis A and showing how things spread to the community, again, that seems a bit misleading because hepatitis A is a completely different type of transmission and how it works. And so how come they didn't show an example of how like Hep B or Hep C or HIV spreads? Because that's typically a more specific group with risk factors there.
Well, I think that by reducing the amount of Hep C, Hep B, and HIV within the drug using population, if there is a needle stick injury to our law enforcement, other first responders, or to nurses or physicians who are attending these people in the healthcare system, if we have a decrease of incidents in that population, we're reducing the risk to the rest of the community and these people who are providing care to them.
Yeah, but a lot of people in the community aren't participating. I understand there's still some risk, with interactions of some sort, but it's going to be completely different than a flu or a Hep A, that kind of thing, because the population at large isn't, involved in the risky behaviors of these types of transmissions.
Well, Ms. Ackerman, if I may, I think you brought up a really great point that I guess I wanted to highlight, which is that the reason for the motivation for the harm reduction program is not only to care for a troubled community, it's to prevent the spread of disease into our entire population, which is actually possible. And I will share with you candidly that having been to major cities over the last 10 years in our region, but certainly across the country, Chicago, San Francisco, Los Angeles, you see needles on the street everywhere, and there's concerns and even stickers that say don't put your hands in the garbage because of the potential for sticks. It's important for me personally in terms of our stewardship of this program that we reduce the incidence of illness that can spread to other people in the population, but municipal workers who are handling waste or police officers who are having to do a pat down deserve to be safe. And anyone who has been stuck with a needle gets very concerned. And there is a tremendous cost to local agencies when that happens. So I just share with you candidly that it spreads very easily. And so it's not just a focus on this population. It's a prevention model that allows for the reduction for the entire community. And that includes children and, school children who are on the street or who may be potentially playing in parks and recreational areas where in many communities, parents don't actually send their kids anymore to those school playgrounds because they have so many needles in them. So this is really a stewardship for the entire community.
Yeah, and I understand that, but it would be more helpful to have statistics from those specific things than a completely different disease.
Yes, and I think you're
Situation.
correct. And I think the idea of getting more local statistics will be great. I think that because we've been so successful over 3 decades, we don't have the statistics locally, but I'm certain that we can find some that are more representative of a rural community like ours.
Is there any effort, like we do referrals, but how much is that emphasized? And is there any partnership with the faith community, addressing the spiritual component, which is so important in many aspects of addiction?
Not something that we currently have a partnership with, but I absolutely agree with you. I mean, I think that for many people, just because they're using drugs doesn't mean that they no longer have a spiritual faith, and something to think about.
All right, thank you.
Yep.
All right, well, thank you, Commissioner Lindy. And then we have Council Member Byers, Dr. Barg, and Ms. Duval, and Commissioner McKinney.
All right, thank you, Commissioner Anderson. And Melissa, I thank you for the presentation, and I appreciate the dialogue and the questions. I will admit that as at first glance, this whole idea seems a little counterintuitive to me, but as you explained, as you're taking this comprehensive look to disease in general, it makes more sense to me. There was one, obviously the perfect solution is prevention and not getting involved with these drugs in the first place, but you've got to deal with it after the fact as well. The one statistic that caught my eye, well, before I mentioned that, Daleen had mentioned churches' involvement, and I will mention that our church has a specific addiction recovery program. It's not tied into the health district per se, but it's modeled very closely on the 12-step program from Alcoholics Anonymous, but we use that for people in and out of the church that are interested. That having been said, the one statistic that caught my eye was the idea that, that number that said that those involved with the program are 5 times more likely to be able to leave their addiction behind. And I was wondering what you attribute that to.
Having immediate access to treatment. So for many of these people, they feel devalued. They don't see any hope. They don't know the resources. They aren't connected to services. And so by coming to a syringe service program and us always being ready to take them as soon as they're ready, it just promotes recovery, because they can, as we know, with addiction, they might be ready next week, but they're not ready today. And so just always being available to get them into services.
Okay, so I'm assuming then that along with, you're not just simply handing out the leaders, the needles or the syringes, but you're also offering opportunities and offering education to them.
Absolutely. What
Okay.
can I help you with today? What's your biggest burden? Do you have food? Do you need help with housing? Do you have a wound that we can look at? That's the approach. It's not just to hand out the syringes.
All right, thanks, Melissa.
Interested in treatment today?
Thank you. Council Member Byers.
Thank you. I just wanted to, I did a quick little mathematical thing here. And where it says in 2021, clients served and needles exchanged, the clients served was 2,898. And the needles were 235,950. That worked out to about 81 needles per person that was served. And considering when somebody is active in their addiction, I think it's probably much higher than 81 needles per year that they're using. So, I just think that continuing offering that education that, every needle you use, we want you to bring back in so that, they're not using a needle twice, or they're not finding other sources of needles, would be a really critical piece. The other is that, and thank you, Commissioner Lindy, for bringing this up. I know there are faith-based programs that are similar to AA. I know there's AA, I know there's NA, and I can name half a dozen faith-based services in this community, including the church that I attend, that offer spiritual programs for people. So I'm wondering if at the needle exchange that information is available, if those service providers, NAAA, and any spiritual group, can have those materials available at any time.
Absolutely. We keep information out there about comprehensive, UGM, Camp Hope, any information or pamphlets you have that you feel would be helpful. We're absolutely willing to have those out there.
So I know some people that are connected with 2 or 3 different churches that do celebrate recovery. So I would just, I'll encourage them to make sure you have ample supply on hand. Thank you.
Thank you. Dr. Barr.
Yeah, I just wanted to point out that there's very well-established pathways from that. The start is needle exchange and it ends up with control of HIV and cure of hepatitis C. So needles are very important mechanisms of spread for both of those diseases, particularly hepatitis C. Sex is a very small way of hepatitis C movement. So what happens with the HIV patients in particular, their positive test is followed up and they're referred to New Hope, which is the HIV clinic in town. And when they are seen at New Hope, it doesn't matter if they have insurance or not, because there's a special program called the Early Intervention Program that's funded by DOH. And that lasts for a year. So all these people are probably in that year have their HIV completely suppressed and their health is greatly improved by the administration of the HIV drugs. During that year, the caseworkers at New Hope will get the patients insured, so continued care will go on. So this pathway is very well established and very successful. And then with Hep C, if they get referred, for instance, if they're HIV Hep C co-infected, New Hope Clinic takes care of them. If they're referred to the hepatitis C clinic, which is run by an ARMP who's quite skilled at that, they will receive their treatment. It's a 2 to 3 month treatment, depending on the response to therapy. And for Dr. Atterbury, the costs of these drugs have plummeted because multiple ones are out there and big contracts are being arranged. So they actually used to be $70,000 a patient. It's much, much less now, although I can't quote you the exact number. And one thing great about the hepatitis C treatment is it's greater than 90% cure rate. So well worth the investment, given the cost of liver transplant if they develop cirrhosis. So that's all I had to say. Thanks.
Thank you, Doctor. Ms. Duval.
Yes, thank you. I just wanted to point out, in case nobody knows, but my maiden name is Prieto. In the notes, I did forward that motion and brought it to the Toppenish Council to support a needle exchange program in our community. I support it then in 2019, and I support it now. And I envision a future where our mobile services can provide these essential and very important services in our community, in all of our cities in Yakima County. It is kind of, I think, a burden where everyone in lower valleys or in small communities have to go to Yakima to do these needle exchange programs. And hopefully we can work again and bring it to at least Toppenish as your budget allows. But I have gone on ride-alongs with police officers where they've had to pat down people, and it is dangerous. And I've heard concerns from our businesses that, you know, that they're taking out the garbage, that they have to be careful. And as myself using public parks, I'm very conscious that some people can dispose of them irresponsibly. And I walk around the playgrounds to make sure that my kids are safe, because you just never know. And that's the world we live in. So thank you so much for these services. And I think that they're very important.
Thank you. Commissioner McKinney.
Yes, thank you. Melissa, you had sent an email to me with a couple of graphs because I'd asked for 5 years worth of data. And I thank you for that. And I was hoping to see that in the presentation. but I just want to confirm the data that you provided showed, I asked for individual referrals, and based off the chart that was provided, that equated to 17,801 people in 5 years. So are you really thinking that those are individual, or were those annually individual? So for instance, in 2017, it was about 4,893 people. So are those truly individual?
When you say referrals, are you saying encounters? Like they came to our
So my
service?
question to you is, how many individual people have been served year over year in the last 5 years? And you provided a graph, and it says 2017 individual people served 4,233. So
Sorry, you said
really
referrals,
encountered.
I was a little confused. But those are actually encounters and not individual people, because it's an anonymous service. So we don't keep track of the individual. I can give you anecdotally that there's probably 300 people that use our services.
Okay, so that's important because it actually goes to Councilwoman Byers' question, which was why I was driving at that data before this meeting, because we have the numbers do matter based upon if they're individual encounters versus how many individuals we're actually serving. So you're saying that roughly 300 people each year you're seeing consistently use this program.
Correct, but that again, it's really hard to determine, because when you're looking at a homeless population, many of them have their designated duties, right? So some might be responsible for bringing back the syringes for the whole group. If we're serving people down in the lower valley, they might be collecting for a whole community and bringing them, and there's only one person coming. It doesn't truly give us a true number of how many people are actually representing these needles. Because
but it's definitely a much lower number. So you're thinking it's in the hundreds rather than you're servicing 4,000 individual people.
Correct. Those are encounters. So how many people we see each week.
Okay. And then you just mentioned this, and it's been brought up several times, that most of these folks you're saying that are the folks who are in our homeless community, which really drives me to this thought process of the self-harm reduction. And it seems that this philosophy is very singular focused on the cost of health, avoiding health costs to the community. But unfortunately, it completely ignores the cost of the criminal activity and to our criminal justice system and to the public safety and other aspects. And it's heartbreaking to hear Councilwoman Duvall talk about having to, go through a park and look for needles. It's just a terrible, terrible thing for any parent. I know that there are a lot of folks in other communities who are experiencing that for their kids walking to school. But we do have, unfortunately, a rise in violent crime. And if you ask any law enforcement and you look at the data, drugs are the driving force between our domestic violence, for our gangs. And so I think it completely overlooks the cost of perpetuating drug use and the actual cost. It's not just the health cost. There is a cost to the public safety, the perception of public safety, and to our criminal justice system. And as I can speak from the commissioner's perspective of a budget, it is immense. And now we have, unfortunately, in Olympia, our legislators have removed yet one more opportunity for folks who are suffering from abuse, because when they are encountered by law enforcement, they are not required to enter into the system because it is no longer illegal to have simple possession. So we have a public health system that is providing these opportunities without requirement to participate in treatment. Our law and justice system is not requiring treatment. And I don't think it's a wonder then we can see that our violent crime as it relates to drugs is continuing to increase. And it is an immense cost to all of it financially. So I think it's important for us to really think big picture here. And then the last thing I would just say is I think it is voluntary. And I just want to point out the philosophical inconsistency as it relates to allowing people to choose whether or not to reduce their own harm for doing drugs. But in our state especially, we force people to get a COVID vaccine under duress of having their job taken away from them, or being able to be around their parents or their grandparents who are in nursing homes, being able to volunteer in their child's school. To this day, you cannot enter a school and volunteer in a child's classroom if you're not vaccinated for COVID. And yet we are allowing people to make the choice whether or not they want to get off illicit drugs. So I just want to point out the philosophical inconsistency. And I wish that everything, if we felt like we wanted to reduce self-harm and allow it to be voluntary, it should apply to all things.
If I may, Commissioner McKinney, I did want to share something that you said about law enforcement. Again, one of our commitments to law enforcement is to ensure that those who are serving and protecting our community are themselves safe. Having worked side by side with law enforcement on the street, the concern for violence is very real for a law enforcement officer, but also needle stick injuries is very, very concerning for people because it can impact their entire lives and the lives of their family. So we are always interested in that. But I would also share candidly that this is a lovely valley. It's a place of incredible tenacity and prosperity, but it's also a place where people use drugs. And before there was this program, there were drugs in our community. And sadly, those who are addicted to drugs will find an opportunity through theft and through not just reuse of needles, but literally breaking into homes or stealing from their family members. And so part of what we believe is that by doing this program, we actually reduce the type of thefts and concerns that you're very much interested in. Sadly, these things would continue even if we didn't have this program. So I share your concern about the immense cost and impact of drugs, but I would also share that many of the people who show up at our needle exchange are also members of our working community. They're working, they're caring for their families, and they're also addicted to drugs. They show up in cars, they come from work. It's pretty clear that people at all levels of our society are addicted to drugs, and we're trying to help change that. So the prevention that you're concerned about is one we share.
Thank you for that comment, Director Fresco. And I absolutely acknowledge that this is something, drug abuse impacts everyone. It is across all economic spectrums, excuse me. But what I will say to your point about law enforcement, I'm very well informed about the dangers to law enforcement. My father's a retired law enforcement officer, and I will tell you sadly that given the state of things, he consistently states that he would never go into the profession again. And I will add, it's not because of the dangers of finding needles, it's because of the dangers that have been created by our legislation, because we are seeing an increase in activity because we have decriminalized so much of this. And if I would love to give a plug for drug court at this point, because when we actually have people who encounter the system and they actually enter the system, which holds them accountable and provides them the support, immense wraparound support, and treats holistically their personal relationships, their abilities to get an education, their abilities to get insurance, licenses, renew relationships with children, get a job, get a GED. So by the time they exit drug court after 2 years, not only are they sober, but they feel confident and understand their value and worth that they have, and they are contributing members of society. They've rebuilt strong relationships so they don't return to that very dark place where they came from. And the only way they get into that system is when it's forced intervention. There has to be a carrot and a stick. So if you want to learn more about drug court, I would love to invite anyone to come to me because it's fantastic.
Dr. Cleary, you had your hand up. You still would like to comment?
Sure. Yeah, there's a gut reaction to the idea of giving out needles that it may promote more crime and such. But the reality is this has been going on since the exchange programs have been going on since the 1980s in Europe and since the 90s here. And there is just a wealth of documentation of studies that have shown within communities that have gone from no program to having a program that there is a marked reduction in crime. And it's even pertinent, in the current time period because federal laws were changed in 2015, well, actually finished in 2016, allowing federal funding for these programs. And so there are a lot of communities who have recent data showing the changes in their community in both infection rates, hepatitis B, hepatitis C, hospitalizations, crime. The statistics are very solid, and despite what somebody might think about drug use in general, it definitely helps the entire community to have a program like this.
Thank you. Dr. Barg.
I just wanted to make a couple comments about mechanisms for intervention. So it really is dependent on disease and the contagion, for instance, like hepatitis C and HIV are much less contagious than COVID is. So different measures would be necessary. Mandates may be necessary to control contagion of one disease, and not policies may be, and practices may be able to control other diseases. So it's really disease specific or problem specific. As in many things, one size doesn't fit all.
Thank you, sir. If there are no more comments on this subject, we'll move on. We have quite a lot of the agenda still to cover. So I will now move on to the highlight of our meeting, Mr. Porter.
Imagine you're being a little facetious there, Ron, because unless you guys all really love those numbers. Please, would you bring up the financials starting on page 11? I will go quickly. You guys have a lot to discuss today. And we also have a budget presentation at the end of this, in the new business section. So I will move quickly, but please stop me if you have any questions. For the month of August, we had a large gain of 223,000. So through the month of August, year to date, we have an excess income of 981,000. Our allocated budget for revenue was 13.8 million, and our actuals coming in at 7.7 million. And for our expenditures, the allocated budget was just under 14 million, and our actuals are coming in at 6.7 million. Next page, please. So our major gain had a lot to do with our MAC billing. So we have, I talked about it a few months prior, we have a Medicaid admin billing that helps reimburse for our highly compensated employees. So that was driving the large increase, mainly for the month of August. For the financial income statement here, what I really would like to concentrate on here is the year-to-date piece. The foundational public health, you can see, is over by $500,000 compared to budget, while the federal money is under by 6.8 million. As you all know, the federal budget was designed to have to be in full COVID activities, that we would still be running test and vaccination services, and those have discontinued. What we're seeing is a shift towards foundational public health services. Those are a lot of services that are mandated services that we are required to do, that did not have specific funding in prior years, is now receiving funding. Public health was not invested in for a very long time. Just up until these past few years, public health has now become a very major concern across the nation. And so we're starting to see a shift in that funding. As COVID's going away, foundational public health is starting to take over, so to speak. Any questions regarding that? And I mainly bring that up because of later on for our budget. And as you can see, the most of our year-to-date differences are down. And that's because, like I said, we had budgeted for COVID. As you can see at the bottom, there's a large difference of 6.4 million for professional services. And that's the main difference between that's why our federal funding is down. Any questions? I'm seeing none. Next page, please. Second half of the income statement. Next page, please. Moving into the programs. Again, as we added all these FPHS programs a few months ago, or last month, I believe even, we're starting to see more of a shift in that direction. And these will start to become some major programs for us for the future. Scrolling on down. Any questions for the programs? Next page, please. And then finally, the cash flow. Oh, sorry, we have the COVID income statement. Next, please. As you can see, a major drop off here. We've total expenses through the year is 2.6 million, with just only $53,000 for the current month of August. Last slide, please. So for the month of August, we receive our flexible dollars. Well, actually, it's in July, but the way the money came in, it came in like at midnight on the 31st, so it posts in August. So that's why we receive, and that's $500,000, excuse me, we receive $1 million in flexible funding, foundational or public health funding is that, and we receive $500,000 at the end of January and $500,000 at the end of July. And that's the reason for the uptick for August, because I ended up posting on August 1st. And that wraps up the financials. Is there any questions regarding them?
Any questions for Mr. Porter? If not, I will entertain a motion to approve the August 2022 budget.
Commissioner McKinney, I so move to approve the budget as presented.
City Council Patricia Byers, second.
Moved and seconded. Any further comments or questions? Hearing none. All those in favor, aye.
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 All those
Aye.
opposed, same sign. Motion passes. Thank you, Mr. Porter.
Thank you.
We will now move on to agency reports, and first up is Mr. Fresco.
Thank you, Commissioner Anderson. Good morning to the board and those who are watching. Thank you for joining us. I wanted to begin by first off thanking the board for the conversation we just had. I think it was a robust conversation around an interesting and difficult topic. These are not easy issues to address, and so I want to thank you for your candor and also your patience in allowing that to flow, and means a lot to us personally. Thank you. I wanted to discuss three things, please. The first is you'll hear more under new business about the budget that we will be presenting to you. Again, we attempt to do that in September so that you have time to review it. Our goal is always to have a strong budget, and this year we do. There have been in years past where we had uncertain funding for the next fiscal year. We've had reductions sometimes of 20 to 30% proposed for public health funding. That's not the case this year. So it's a strong budget. It's one we're confident in. It allows us to retain our staff. And I think that you'll be pleased with that when it comes up from Chase. Thank you. The other is I did want to share that part of our goal over the last few years was to anticipate what happens during a transition from COVID. As you recall, we've had many funding sources that were from the state and federal government regarding COVID funding, and it was a lot of money, but the reality was that those funding streams will turn off, and sometimes they turn off indelicately, and you're left with the reality that you have new staff, that you have new programs, you have new initiatives, and frankly, new responsibilities to serve the community. So the ability to stay nimble means that we have to retain and hire quality staff, and it's expensive to do so in this environment. And the board has been very supportive of that. Thank you personally, but we also have to plan for that. So we have a strong budget, and our goal, again, is to anticipate a 3 to 5 year transition from COVID so that we maintain the ability to serve the community, to be nimble, and also have the funding to retain our staff. The third thing I wanted to share is what Chase alluded to, our new reliance on Fphs, which stands for Foundational Public Health Services. That's a concept that's been introduced nationwide, but it's something that we at the health district here and other jurisdictions around the state advocated for from the state legislature. The idea was to have dedicated funding from the state legislature that would allow local health jurisdictions to invest in the ability to serve their communities. And we are talking about 30 years of reductions in funding in this state for public health. So this is really about strengthening our ability to serve the community. And also the idea, very important to me and our staff, is that we in rural Eastern Washington know that often we are overlooked when it comes to funding and opportunity. And we believe strongly that your health should not be dependent on your zip code. So we want children born in this community to have the same opportunity to grow up healthy and well as others who are in larger urban centers. And so that means we need more funding to do so. The Foundational Public Health Services funding has increased year over year and is allowing us to really strengthen our services. As Chase pointed out, they are mandated services. They are the services that we really believe are foundational to our abilities. They're not always the exciting services, but they are necessary. So as an example, you have to have a strong human resources department. You have to have a strong financial management department and have fiscal discipline. You have to have the ability to invest in infrastructure and technology. And you also are investing in areas like preparedness and epidemiology and communicable disease response. So those are the areas that we're focused on, and this foundational public health services money allows us to do so. I wanted to share that as an overview before we have our presentation of our budget, and happy to answer any questions if you have them.
Any questions for Mr. Fresco?
Just one, Andre. The foundational money, is it coming out of general tax base, or is there new taxes being passed on to Washingtonians in order to fund the foundational programs that potentially weren't being funded before?
No, it's not new taxes. It's coming from the general fund. It's specific and it's supported by the legislature. I will share with you that that's one of the concerns, and that's why we have to be very diligent. So thank you for the question, Dr. Atterbury, because this is not nothing in legislative money is guaranteed, as you know. And so when we start building opportunities, when we're hiring staff, when we're creating programs, we want to have numerous sources of funding to be able to afford that. So that's why I'm cautiously optimistic, because again, this is a new process, and there are many obligations that the legislature has to fund things in this state. So we are taking a cautious approach, and in the coming months, I will be talking to you about other ways for us to invest. Thank you.
Thank you. Without further questions, we'll move on to Dr. Barg.
Good morning, everyone. A couple updates on our usual problems. COVID starting out, about 4.4 million people have received the newest booster, which is bivalent, meaning that it has multiple strains protection. So the old strains that caused all the problems in the past, like Delta and Alpha, plus it incorporates material to protect against B4 and B5. The recommendations now are to obtain this second booster sometime in October to have the best effect through the winter. Also, there's a good chance we're going to have a surge in influenza in contrast to previous years, because there's more gathering of people that will be going on and less mask use around those gatherings. In the winter, typically people spend more time inside, which brings them closer together. So we're anticipating double infected people, and whether that adds up to more hospitalization or not, we'll have to see. But the vaccine will reduce the chance of hospitalization and severe disease in either disease. And as I told the Rotary last week, God gave us two arms for that reason, one for influenza and one for COVID. You're supposed to laugh. The next thing I think is a little bit more disturbing. The number of infections is increasing in Europe and the UK, and that often predicts that it's going to go up here, since we usually follow those areas. The other thing is, as of September 22nd, there actually has been a bump in cases, although deaths and hospitalizations still continue to go down, which is a good thing. So that covers COVID, except for one disturbing thing. There's now a new strain called B7, and it makes up about 3% of the cases in the US now. Hard to know what the vaccine effect is, but it's probably going to have some crossover. We'll know, I think, in a couple weeks how well this protects and how virulent this strain might be. So it's taken a little longer for this new strain to emerge than it has for the other strains. So hopefully it'll continue over the next year to take longer and longer for the new strains to emerge. Just a quick thing about monkeypox. This pattern of the lesions are seen more in the genital and oral areas than previous outbreaks in Africa have shown. And a lot of the information is being disseminated to the providers about looking in the oral cavity and looking in the genital region to see if they can find evidence of monkeypox. We've had several patients with typical lesions that haven't cultured out, so it was another problem. And I think Melissa, you can correct me, there's still only 5 proven cases in town. Yeah, which is really great. The vaccination process is ongoing and people are making appointments and coming in every day. I think there's about 50 to 60 people so far that's been vaccinated, and most of those are through a clinic in farm workers that's been set up. And Melissa, do you know if Neighborhood Health set up yet?
They are, yep.
Good,
Partnerships with both of them.
Yeah, so we're concentrating on the high-risk patients and the patients who've had known exposure to monkeypox. Vaccination will prevent them from getting it. One other thing about COVID, there's a lot of debate last year about whether this long COVID was real. And I think most people now that take care of COVID patients really believe it is real. And it's similar to the sort of long-term fatigue that you see after mono and probably a lot of other viruses. And along with that, there's an increased risk of long-term neurologic disorders in COVID patients like stroke, memory loss, peripheral neuropathy, migraine headaches, seizures, encephalitis, and a few more. So in certain studies, it's been shown that vaccinated people are less likely to develop this long-term. The real problem is we just don't have enough providers to know how to deal with this. And it's not going to be fixed anytime soon. But we don't, we as a health district don't have any way to help people with this problem, because what we need is good doctors that know what to do with these folks. Last thing, it's really actually interesting that all of us came upon this issue of funding for public health. The New York Times had a very good article about the lack of data that actually ends up blunting the U.S. response to outbreaks. So things start with surveillance, and then they move on to dissemination of information to various sources. There's really, similar to 9/11, the agencies that collect the data aren't sharing the data effectively with each other, and there's multiple computer systems and data banks that aren't talking to each other. So this lack of comprehensive and timely data probably led to worse outbreak of COVID and monkeypox, because information didn't come up to policymakers in a quick time. And that's generally a result of underfunding and decreased funding for public health. And I think one of the outcomes of COVID and monkeypox is perhaps they'll start working on coordinating these information systems. Because really decisions about epidemiology and spread and treatment all rely on good data. So that's what I have to say today. Any questions? I'm happy to answer them.
Dr. Barg, just a quick question. Is there any discussion either at the state or federal level about ending mask requirements in hospitals or doctor offices, or are those with us for the duration?
Yesterday, they decided to end mask mandates in hospitals, except in areas where there's high level of transmission. And also if you work in an area of the hospital where there's particularly susceptible people, like say an oncology ward or a transplant ward. So whether that's the right thing to do or not is hard to say, but literally yesterday, CDC came out with that recommendation.
I'm always good for timely questions, sir.
Well done. Well done.
Well done. That's right. Thank you. All right. Next, we'll move on to our chief.
Oh, Commissioner Anderson, I'm sorry. I just had one more of a comment. More of a comment just in concurrence with the statements from Dr. Barg with the information. I think, the lack of information sharing also contributed to unfortunate public health policy dissemination, where we have a one size fits all, which you've brought up many times as not being the right answer. Specifically, we still do not in our community have the data that shows specifically, my interest was in children with COVID who presented at the hospital. We still don't have the data to show that of those children who've been hospitalized and fall in our COVID numbers, whether or not they were hospitalized because they were incidentally found to be had COVID positive because they broke their arm and they presented, or because they had symptoms and were actually admitted due to COVID symptoms being thus that they needed treatment. So I would concur that sharing of information would only help all of us better understand the impacts and how best to move forward in the future.
Thank you. All right, we'll move on to Chief Operating Officer Ryan Eibach.
Okay, so I've got two issues I want to update to the board. The first one, as many people know, as of October 31st, the COVID-19 emergency proclamations and state of emergency will go away. So what does this mean for K through 12 schools? So what that means is that many of the requirements in K through 12 schools will become recommended strategies to mitigate COVID-19 transmission in the schools. It also means that the vaccination requirement for employees, volunteers, and indoor contractors will also go away. The State Department of Health will still continue COVID-19 testing and vaccine efforts. And also COVID will also still be a notifiable condition. So schools will continue to report to the Yakima Health District on COVID numbers. And then the other issue that I want to update you on is a few months ago, the Yakima Health District entered into a memorandum of agreement with the county to help remove debris from abandoned encampments along the Yakima Natchez River floodplains. And so as of today, there's been about an estimated 9 tons of garbage that has been collected and bagged up. And on October 5th, we've used fundings from the grant that we have with our solid waste grant that we have with Department of Ecology. And so some of that funding will be used to airlift these 9 tons of garbage out of the floodplains. So we're happy to announce that and report what the money from our State Department of Ecology solid waste grant is going towards. Any questions on either of those issues?
I don't have a question. I just say great job.
Yeah, I would echo that. The county's appreciative very much of the partnership, and 9 tons doesn't even scratch the surface of what we are pulling out because of these illegal campsites across our communities. So we're appreciative because every agency we can partner with allows us to get that much more. Unfortunately, they just move around and dump more garbage, but we continue to come in and try to clean it up to protect our environment and for public health reasons.
Yeah. Thank you all. All right, we'll move on now to Mr. Nathan Johnson.
Morning, everybody. Just a couple high-level updates, one of which is we are still activated for COVID and monkeypox, as Ryan mentioned, with the state of emergency for Washington going away October 31st. We're having internal discussions on what our activation looks like and how we continue some of this work that will still be ongoing related to COVID, specifically with our long-term care facilities and working with them with education and vaccines and things like that. So the work will continue. We're just trying to figure out what that exactly looks like. As far as monkeypox, we do still, we're still getting some vaccine. We just recently got 40 vials. On top of, I believe we had about 130, 140 vials before that. Previously, when we first started vaccinating, we were only vaccinating close contacts to confirmed cases. We have since slightly opened that up, recognizing we do still have vaccine available and we have a very high risk population that is eligible for the vaccine. So we partnered with the New Hope Clinic specifically, as they have a client-based or a client base that is specifically high risk. So they've started vaccinating their own patients, and that's what Dr. Barg was alluding to. And we're working with Neighborhood Health also to see if they have any client base that they can specifically link to being and meeting that high risk criteria. So that is going forward. And then I think the only other update I have is earlier this month, we participated in what is known as a tabletop exercise with the Yakima Valley Office of Emergency Management. They hosted a tabletop exercise, which is basically we get a whole bunch of partners in a room and throw out a scenario and kind of start talking about what a response to that would look like. This was in relation to a plane crash with about 60 patients at the Yakima Valley Airport. The airport has to do a tabletop every year, and then every 4 years they have to do a large functional exercise where they get the actors out there and they kind of run through things. So we had great discussions talking about things such as patient movement. How do we get 60 patients to the hospitals? talking about family reunification. So once the patients are at the hospitals, we're able to link them back up with their families who are searching for them. And then also fatality management. So how we work with the coroner on identifying deceased and linking again those back up with family members afterwards. So great discussions. Now that COVID's slightly, going down, we're starting to be able to have a lot of these conversations, not only locally, but on a state level as well. So it's encouraging. And that's all I have from my side.
Thank you.
Question. I don't know if it'd fall under your jurisdiction, but is there any findings of rainbow fentanyl with Halloween being right around the corner? Is there any findings of rainbow fentanyl in our community? And if so, is there any parent education or even child education documents that we're distributing or trying to get the message out about the dangers of candy flavored with fentanyl?
That may be more of a Melissa question. I haven't heard of any of that from my side.
Unfortunately, none of that is reportable. That would be a conversation that we can have with the coroner's office and then, of course, the ERs to hear what they're seeing. But I agree with you. I think that's some great messaging that can go out and something that Lily can work with the board on how messaging and how to target a specific population, because that is very concerning because it has pictures of it and it looks just like candy. And
All right. Any further questions or comments? All right.
Actually, on just to piggyback on that, I'm just wondering, maybe it'd be something that Ryan, have you heard anything since you're our school, liaison about anything in our schools that they've been able to discover?
I have not heard anything about it.
Thank you.
So it seemed to me that schools, excuse me, would be a great place to disseminate some educational materials.
we've throughout COVID, we've developed partnerships with our ESD 105 who can disseminate that information for garage door nurses, etc. The only thing I've heard from nurses is there seems to be a dye bug going around. That's the only thing I've heard feedback on.
All right. Thank you.
I would share, Commissioner Anderson, if I may. I mean, I know it sounds antique of me, but it was always a concern around Halloween, around what people could add to candies. And so we didn't want people ever to take apples that might have razor blades in them. We didn't want people to distribute candy that wasn't wrapped. So this is great community messaging. The idea that there are, the reality is there are drugs in our community and we don't want children to become impacted. So thank you for that.
Yes, and I'm happy to follow up with some of the school-based groups that work around substance use prevention, and I'm sure they'll have good feedback so that we can use that for future messaging. Thank you.
Thank you all. All right, we'll move on to Miss Melissa Sixberry.
The advantage of Dr. Barg and Nathan going before me is that they cover a lot of my report so well, but I will just speak on monkeypox a little bit. That Dr. Barg, yes, we do, it's correct. We do have 5 current cases, confirmed cases of monkeypox. We haven't had a case in several weeks now, which is great. We attributed to we were able to quickly using New Hope Clinic, which is specific to HIV clients, and through our other farm workers clinics and neighborhood health. There are 572 cases across the state of Washington and 16 hospitalizations. We are seeing a trend downward in across the state and nationally, so that's all good news for monkeypox. For TB, we still are managing 4 active TB cases, which is the same 4 that we had the previous month. Again, most of these patients are with us for 6 to 12 months, so we continue to follow them. I have a new STI nurse starting next week, so I'm very excited about that. She's coming to help with our syphilis outbreak, and of course, we've always had high STI numbers in this county, and so we have one that Department of Health recognized the need and has given us funding to fund this nurse specific to STI work. So excited to have her start next week. And then also we, as many of you know, if you've seen on our orientation presentations for our TV program, it used to be that we have to go out to see our clients daily to watch them take their medications. And then once they were, which is a high cost, because we would see people in Tieton, Grandview all in the same day. It was cost for nurse time, it was cost for travel expenses. So several years ago, we implemented the video DOT, which allows us to be HIPAA compliant and observe these individuals taking their medication through a smartphone, which has drastically reduced the cost of our TV program. And that's something that we were piloting, that we were using for the last several years. And DOH has recently, just in the last month, used us as a model and has now implemented that statewide and has now taken over the funding cost for that for all counties in the state. So very proud to be a part of a model for the state on video DOT and the effectiveness and efficiency of that.
All right, good job. Thank you.
Well, for me.
Any other comments? All right, we'll move on to Mr. Sean then. Mr. Sean.
Morning, everybody. I'll be as brief as I can, as I know we have a lot to get to. We've been busy in environmental health. We have Andy here who started a couple weeks ago and getting trained up as quickly as he can. Andy will be backfilling a position from one of our environmental health specialists who's retiring at the end of the year. Mr. Silvestri will be entering retirement December 31st. So congrats to Ted on that, and welcome again, Andy. We have the state fair going on right now. We do have always have a presence at the fair. We have 4 of our environmental health specialists doing the food inspections of all the food vendors at the fair. We have a lot of vendors this year. We have 78. So we're out there about, close to 20 inspections per inspector, and we go out there the day the fair opens, make sure everybody has all the documentation, they need, permits, food worker cards, and we do their initial inspection. And we'll be doing their second round of inspections this week. I know some of those have already been completed, and the rest of those will be probably be completed today. So lots going on at the fair, and everything's going well, going smooth. Seems that we're having a real successful year at the fair this year. The next thing I want to touch on is there's been a lot of attention around the DTG limited purpose landfill up at Rocky Top. So I wanted to address some things in relation to that issue. A lot of media requests for interviews. There's been a lot of contact from the group Friends of Rocky Top, also known as FORT, with some concerns they have about the operations of that landfill and some things going on in relation to the hydrogeological investigation for groundwater vulnerability and landfill design, the issue of the gas emissions coming from the landfill, and as well as some unacceptable waste issues that have been going on. So I wanted to briefly touch on what's happening now, what we're currently doing out at that site. So in our biweekly meetings with Ecology and DTG, we have talked about the hydrogeological investigations. It did identify some groundwater vulnerabilities at the site in current and future fill areas. DTG has committed to Ecology and the health district to lining all future fill areas of that landfill. So they are going to be moving forward with a liner leachate collection system in all future areas. We'll be looking at a cost risk analysis being performed by the environmental consulting firm that DTG works with on the current fill area to determine if a liner is needed underneath that existing waste, or if they can seal over the top of it. And that'll be done based on, the groundwater vulnerability and hydrogeological investigation that's ongoing. But the good news is we have some solutions moving forward that groundwater vulnerability concerns with going forward with liner, and we for the commitment on moving forward with that. So for the gas emissions, it has been identified by the Department of Ecology's toxic cleanup program that some compounds in the gas emissions are above the state MOTCA cleanup levels. So what that means is something has to be done. currently, what we're waiting on, or the next step, is there will be a letter coming from the Department of Ecology directing DTG on next steps for additional testing and sampling to be done, which will help narrow down what cleanup efforts will be put in place to mitigate those gas emissions. Whether it's excavating material out of the area, and to be clear, the area of the gas emissions so far is pretty isolated to a specific area in the old fill site. So we're hoping that if it's an excavation mission to clean that up, that it won't be extremely extensive, and we can target that certain area and fix those emissions. So we're waiting on the letter to direct next steps. DTG is committed to that process as well, and cooperating with the health district and ecology on that cleanup effort. We have also received a large amount of complaints of unacceptable waste that would be qualified as municipal solid waste: mattresses, tires, food wrappings, things like that. This is a limited purpose landfill, so municipal solid waste is not appropriate to go into that site. In response to these complaints and our communications with DTG about those complaints, DTG has implemented a couple processes to minimize or stop unacceptable waste coming into the landfill. They have a high sorting crew, so they are tipping their loads onto a platform above the fill area. They're sorting through that waste to pull out anything that would be qualified as unacceptable waste before they push the appropriate waste into the fill area. And then they're discarding the inappropriate waste by taking it to a municipal solid waste facility. They've also implemented what they call a black bag disincentive program. So any sealed container or bag that is not see-through, they're charging extra fees to their customers or people bringing in waste, and then pulling those out and also bringing them to a municipal solid waste site. So far, we have seen a dramatic reduction in unacceptable waste. I don't think we've seen any the last few times we've been out there. So far, it is proving to be effective. We will continue to monitor that and work with DTG on any adjustments that need to be made. So that is kind of a high level view of actions that are being taken, things that are moving forward. We feel we're making progress. And this company, DTG, is cooperating and wanting to also make progress so that they can operate and move to new fill areas without concern, and eliminating any risk to human health and safety of those that visit or work at the site, and of course the nearby residents of the site. I'm happy to answer any questions you might have.
Any questions for Sean? Seeing and hearing none, thank you. We'll move on now to Ms. Lillian Bravo.
Thank you. So over the last month, hopefully you all have had a chance to meet some of our staff, of the Yakima Health District staff, as we've been participating in a couple different community events. Some of those being several different national night outs, working at Heritage University's Resource Fair, and even the Family Fun event and Scavenger Hunt over at Sarge Hubbard Park. So always look for our tent and our logo, and please do stop by and say hello to our staff if you see them while they're out there. At each of these different events, we do work with the Department of Health's Caravan, which is the mobile vaccine unit to provide COVID-19 vaccines that's supported by the Department of Health. And at each of these, there's been about 30 people that end up getting vaccinated at each one of these events. So we'll continue that partnership with the Department of Health and these community organizations that are hosting these resource fairs, so that people who choose to get the vaccine can do so at that moment as well. Unfortunately, as we're going to these different events, we are finding that since the new bivalent vaccine has came out, many people actually do not have that information. So we'll be focusing more efforts for people who want to get that vaccine to know that it's available, where to get it, and if they choose to get it and what it's for, and that it is available at this time. So again, for anyone that's interested, we have that information available on yakimavaccines.org and in Spanish, yakimavacunas.org. So if you want to share that out with people, that's the easiest way to find a location where people can get vaccinated, which also include these community events that we participate in. And I did want to share just one more update. Earlier this month, the Opportunities Industrialization Center, or OIC of Washington, a nonprofit here locally, has celebrated their 50th anniversary here in Yakima. And as part of that anniversary celebration, they selected a few different community partners to recognize. And I'm happy to say the Yakima Health District received the Outstanding Community Support Award. And just for everyone to see, it's a nice little, hopefully you can see it. We got a nice little award for being an outstanding community partner. And so, of course, all of us here in public service do not do so for the recognition, but it is nice to be able to see that the work in the community is being recognized as well. And so thank you to all the staff for doing all this work and allowing us to be recognized in that way. And that's it for me.
Thank you. Any questions for our comments?
Just a comment, Mr. Anderson. So I've gone to several of the community events and seen our health district personnel out there, and whether they recognize me or not, it doesn't make any difference. I always try to go up and thank them for being there and see what they're offering. So great job.
Good, good. Thank you. Anyone else?
I forgot to mention since our last board meeting, we were at the Scientific Park for overdose awareness event, and we handed out 74 naloxone kits at that event in a 2-hour period. So
very good.
Very successful.
Very good. All right, with no further comments, then we'll move on to unfinished business. And first up is Mr. Ryan.
Okay. Commissioner Anderson, if you'd like to open the public fee hearing, we can go ahead and move into that.
Okay, I will now open up the public meeting to discuss the fee schedule for 2023.
Okay. We did advertise the public fee hearing in the newspaper and on our website, and the fee schedule has been on our website. We did not receive any public comments or input for the fees.
All right, any comments or questions?
Ryan, would you like to maybe just briefly give a highlight of any changes that are being proposed for the public?
Yes. So one change that was proposed is in the environmental health program. It's the clearance fees. And what we've done is broken down our clearance fees from $149. And it's one is the clearance fee would be a $40 fee. I believe that is $40. Is that right, Chase? Yeah. Okay. $40 fee. That's more of an over-the-counter where we can issue a clearance right away. And then if we do need to go on site, then we would just charge the remaining $109. But this would provide a lot quicker service. And then it'd be something where the public services would be collecting the fee and then transferring the fees over to the Yakima Health District. But it's something where it prevents people from having to go both to the county courthouse and to the Yakima Health District. They can just pay one fee all at once. And so this is something that we've worked closely with public services on.
Good. Any further comments or questions?
Everybody is aware the $40 fee is actually containing a $10 retention fee for public services.
Okay, good.
Just thank you, and I just want to acknowledge the staff at the health district and public services at the county for coming up with this. You guys really tried to find ways to make things easier for our clients who come in and need help, and this is just exceptional and well received and highly supportive. So thank you for coming up with the ways to streamline the process for people.
Yes, very good. All right, well, you see displayed there the schedule for the fees for 2023 compared to 2022. So the proposed fees are, there's a motion. I'm going to ask for a motion to approve that. Is there a motion?
Is it more appropriate to make a motion to have it appear on a future agenda for approval, or are we able to actually approve it during the public hearing?
Yeah, so if we close the public hearing, then the next agenda item is to
yes, I'm sorry.
Propose motion, and that is a board decision.
Yeah. Okay, I will close the public meeting hearing, and then I will ask for a motion to adopt the 2023 fee schedule.
Mr. Anderson, I move that we adopt the 2023 fee schedule.
This is Nyla Duval, and I second.
Been moved and seconded. Any further comments or questions? Hearing none. Mr. Eibach, would you take a poll?
Yes, so if you're in favor of the motion, please state yes. If not, please state no. Commissioner McKinney,
Yes.
Commissioner Lindy,
Yes.
Councilmember Byers,
Yes.
Dr. Atterbury,
Yes.
Councilmember Duval,
Yes.
Dr. Cleary,
Yes.
Ms. Algren,
Yes.
Ms. Ackerman,
Yes.
and Commissioner Anderson.
Yes.
The vote is 9 in favor and 0 not in favor.
Thank you very much. That's all right. We'll now move on to a proposed motion to authorize the approval, and approve resolution 22-01, approving the selection process for members of the Board of Health. Mr. Elliott.
Yes, if you'll recall at our last board meeting, we had an opportunity to review the proposed resolution that we had drafted. There were no additional comments or changes to that resolution. What we need now, this is part of your board packet. If you've had a chance to review it, page 21. What we need now for this, we would need a motion and a vote to approve this resolution, and thereafter then have it identified and signed by our board chair with this day. So I'd ask the board to consider this proposed motion approving the resolution.
Motion to approve.
Second.
It's been moved and seconded. Any further discussion or comments? Hearing none. Mr. Eibach, would you take a poll?
Yes, if you're in favor of the motion, please state yes. If not, state no. Commissioner McKinney,
Yes.
Commissioner Lindy,
Yes.
Councilmember Byers,
Yes.
Dr. Atterbury,
Yes.
Councilmember Duval,
Yes.
Dr. Cleary,
Yes.
Ms. Algren,
Yes.
Ms. Ackerman,
Yes.
Commissioner Anderson.
Yes.
Okay, in favor, 9-0.
All right. Thank you much. Appreciate it. Now we'll move on to the update on a letter to the state legislature requesting the reversal on drug possession laws. Council Member Byers.
Yes, thank you. So this letter, the original letter was presented a few meetings ago, and they asked that I revise parts of it, and I have worked at doing that. And, I think it's important in light of today's discussion we had earlier, which was really a great discussion, that when we talk about community health, we need to talk about not only persons experiencing things in the moment, but how it affects the community as a whole. And Commissioner McKinney brought up a very interesting aspect, and I will agree, because I worked previously in my practice with people who were involved in family court and drug court. And I know how very effective these wraparound services are. So if we are truly trying to help people, change and be rehabilitated into being, successful members of a healthy community, this really needs to be a significant part of what is offered. I've talked to people who have gone through those situations, and I know how successful it can be. So, I know that I think it was Dr. Clary or Dr. Barg, one of the two, talked about not being able to criminalize behavior. And in my thinking, this is not criminalizing behavior. This is an opportunity to really help people who cannot, through drug use and other things, right thinking or whatever, make that decision to make a positive change. I think that having services that are mandated is a very positive thing, because having then gone through those services and coming out clean and sober and productive, their whole pattern of thinking in life and contribution is different, and it's positive, and it's strong. I've seen this so many times. So in the letter, the purpose of the letter is to encourage the legislature to reverse some of the hindrances they put in place for those kinds of things to be more readily put into place.
Any comments or questions?
I move to approve to send the letter as written.
I have some comments.
Well, let's.
Yeah.
Well, we have a motion, and if it's seconded, then it's appropriate time for comments.
Right,
If there's a
right,
second.
yes. Do we have a second?
I'll second.
It's been moved and seconded. Comments? Stephanie?
I just feel that I'm not for this letter, and if someone is feels strongly about this letter, I really suggest that they team up with experts on this issue. I don't feel like, as a Board of Health member, I'm an expert in criminal law or law enforcement. In comparison, maybe teaming up with the Yakima Police Department or the Yakima County Sheriff's Office or the Yakima Department of Corrections or probation or parole officers or public defenders might be a better use of this letter versus from the health department. And there's some typos. So there's an N that should be in. There's a willing that's missing an L.
Thank you. Dr. Cleary.
Well, I'll get back to my previous comment was I don't think we're making a clear statement here. And I think if Councilmember Byers could say in one sentence what the legislation we would like to see contains, then that would be very helpful in here. I agree with her. I would never suggest that we take this as it is written, as there are numerous typos in it. The first paragraph has multiple typos. It goes on to be like a conversation in the second one. I don't think we're the type of people who plead in that second paragraph. But I think one of the main things is it mentions here that this is not a thorough answer to overdose deaths. And that's not what the legislation was about. And I don't think anybody thinks that. I think the issues brought up in this letter, overdoses, safety of the rest of the community is important. And I'm not in favor of decriminalizing drug use, but I think we should be very clear about what we want the legislation to do. So if it is court-ordered treatment, wraparound drug services, and drug court, that should be included in a very clear sentence so that it's understandable what the Board of Health is actually requesting.
Thank you. Commissioner Lindy.
Yes, thank you, Commissioner Anderson. I will agree that there are some grammatical changes that need to be made, just some cleanup in the letter. Other than that, I will say in response to a previous comment about talking to experts, I will say that I have spoken to people that work with the homeless population in our county. I've spoken to our courts, and I've heard pretty loud and clear that there needs to be an incentive or a hammer, if you, for no lack of another term, to help people take stock of their lives and decide that they need to go in another direction. Drug courts, as has been mentioned previously, is a good option to that. But the problem right now with the law as it's designed is on any type of drug possession, the first 2 times that someone is arrested for drug possession, they are simply referred to receive treatment. Not until the 3rd time that they are arrested do they actually are charged with a misdemeanor. The problem with all that is there is no tracking system to even show if someone has actually gone to receive treatment or been referred to treatment. So in essence, we've taken the misdemeanor out of it for all intents and purposes. This legislation, in light of the Blake decision, did lower the charge for possession from a felony to a misdemeanor. And I don't necessarily have a problem with that. But there has to be, again, a mechanism that will help people look at options like a drug court or seek help. That's all.
Thank you. Anyone else? All right. Well, the motion is to send this.
Commissioner Anderson, I'm sorry, I had my hand raised.
Oh, I'm sorry. I was
That's okay.
scrolling up and I didn't see you. Go ahead.
That's okay. I would add comment. I recently attended the National Drug Court Professional Conference, and I can say that overwhelmingly in all of the lectures that I took part in and listened to, that all of these professionals were, I would best describe it as unanimously frustrated with the lack of ability to get people into the system where they can receive these wraparound services and help. They specifically cited the laws in our state and in Oregon as having the pendulum swung too far to the side of allowing people to continue without interaction with the system that is ultimately designed to not only bring justice to the victims of these crimes, because there are many, including children, but also for restoration. Because that's what we're driving at is restoration of someone's whole body and mind and spiritual self to be a valued member of society and know that they are valued. So I believe, I wish that it could be described in one sentence, Dr. Cleary, but I don't think our legislature can write laws that are equally as short and concise. So I think that would be a hard task to try to come to. I believe the letter addresses the situation. And as far as not being the experts, we are the health board, however, and we are representative of the people. And we are prescribed to be able to set public health policy by way of talking to the experts, but also talking to the people. And we don't have governing by experts. We have governing in the United States in here because of we are governed by the people, by us. So it is important to hear the experts and talk to the experts, but it is also important to talk to the people and how they feel the experts are impacting their daily lives. So we have a situation here where I think that it is clear, even on the west side of the state, that the law needs to be fixed. They need to come up with some changes, and what they're asking for, what law enforcement is asking for, what court professionals are asking for, what public defenders are asking for, everyone in the system is actually asking for letters like this from boards like ours to show that there is consensus, to show that this is an overwhelming request from the public, from various agencies and boards, that this needs to change and that we're showing our support and desire for that to change.
Thank you, Commissioner. Council Member Byers.
Yes, thank you. So when I sent this in, it was Friday, and I wanted to make sure I got it in time to make the cutoff for the agenda items. So I didn't have time to edit it because I was doing some other things. So happy to go through and edit it. In terms of terminology, if I use the word plead, we could say strongly urge. I'm not going to fight over words like that. If other people want to write the letter, I encourage them to do it. I will say that I appreciate Commissioner McKinney and Commissioner Lindy's comments, because it really is not just one agency, one group. It's a community as a whole that needs to respond to our legislators, everybody who needs to respond and say, we have gone too far. I am happy to insert usage of best practices like drug court. So I'll make those minor changes, and so you don't need to vote on it today. I'll go ahead and make those changes and bring it back. But I just think the whole idea of what we're doing, it's not specific wordage, it's not typos, it's not anything. It's the idea that we as a board are agreeing with other experts in our community and working alongside them to get this message to our legislators.
Thank you. Ms. Duval.
No, I just wanted to add that I appreciate the effort that went into writing this letter. Now that you are willing to make some of the suggested edits that that were proposed, I think that would be great. Having this topic is really hitting close to home for me right now. Just yesterday, my family attended a funeral for a relative of ours that overdosed from fentanyl. So again, I appreciate the effort. I think that something does need to be done. That's all I wanted to say.
Thank you. Stephanie, did you have your hand up?
For a second, I guess I would appreciate hearing, we haven't heard as a board from any law enforcement officials or for anyone about the need to write letters to support this.
Okay. Thank you. Anyone else?
I would just make comment to say that the squeaky wheel gets the grease, so I don't necessarily need requests from law enforcement. I mean, I think anybody who lives in our community who sees the effects of ravaged, drug abuse and the effects on people's lives, it's a humanitarian effort to try and get people off drugs. It is good for our community to do so, and anything that we can do to enforce that message, I think, is both warranted, and it's our responsibility as a public health board to get that message out. I mean, to sit on the sidelines and say we don't have an opinion suggests that we don't have an opinion. And I think several of us, if not most of us, have a strong opinion about what would be the most beneficial ways, whether that be drug court or other, mechanisms to getting people off drugs, not to continue the legalization, spread, proliferation of drug abuse in our state. I think that we need to send a clear message so that it is unambiguous what we're trying to say. And I would support the letter with the modifications being mentioned. Obviously, typos are typos; those can be corrected. But I think that it's critical that we send out this messaging, because otherwise we complicitly endorse these type of laws, which I can say I do not. I never have. I don't see the purpose in it, and it just seems to spread the harm.
Thank you. Dr. Cleary.
I would just like to volunteer to Councilman Byers that I would be happy to help reconstruct and write this letter with you. I agree with the message. I'm a bit of a stickler for the English language and such, so I'd be happy to work with you.
Thank you, Dr. Cleary. And what I will do is revise it myself and I'll forward it to you, and let's see if we can come to an agreement.
That sounds great.
Thank you.
All right. Well,
Commissioner Anderson, since there's a motion on it, is my motion, and hearing these comments, I would rescind my previous motion.
oh, thank you. I was just going to ask you that. All right.
So my question is, because the legislature is already going to be convening, I feel like the message is a matter of time urgency. So if Dr. Cleary and I can, come up on an agreed upon letter in the next few days, if we could get an email vote to have it sent out, rather than waiting another month.
Is that, go ahead.
Yeah, I would say let's refrain from trying to get email votes and determinations in fear of violations of the Open Public Meetings Act. So to the extent that you feel it needs to get done before our next board meeting, if the board wants to call a special meeting in order to do that, let's do that. But in terms of getting a decision on what's going to be sent out from the board, any vote on that motion needs to be done in an open meeting.
I do suggest that we still have a standing calendar hold for a special meeting that's already on the calendar. If you're able to work together to get that done, I think we have the opportunity, albeit if it's quick, we could have another Zoom meeting. It's already calendared and we could quickly take a vote.
If I can give an update, Ryan will be talking about special meetings upcoming, so that may solve the issue.
Thank you.
Well, I'm just noting that presently it's still on the calendar, so we do have an avenue without calling a special meeting.
Yes, just we're proposing a different day for that, but Ryan can share that.
Okay. All right. Well, thank you much. Great discussion on that. And thank you, Dr. Cleary and Councilmember Byers for wanting to clear up the letter and get it before us so that we can get it sent. Now we'll move on to next is E, approval of the settlement agreement related to the cause case number 21-2-00768-39. Mr. Elliott.
If you all recall, last month we had a discussion related to the ability to settle the ongoing litigation against the Board of Health that was brought in two separate portions, then consolidated from both Arthur West and Angie Gerard. At that meeting, the board authorized me the ability to begin the process of preparing the settlement agreement. In negotiations with both parties on the other side, we finally came to a settlement agreement. In terms of specifics that they wanted were included in here. The settlement agreement has been made part of your packet. It's found at page 25 if you've had a chance to review it. If you will recall, our discussion was primarily focused upon the concept of the amounts to be paid, which are listed in here. I know Dr. Cleary and others wanted to make sure there was not an admission of liability. There's a specific section identified there in paragraph 8. In addition, there wanted to make it was to be made clear through this settlement that this only relates to the Board of Health and that action, that the other actions that are currently ongoing would continue to be maintained. That has been placed in here. And as a specific requirement by the plaintiffs related to this is paragraph 5, a non-disparagement provision that I want to bring to everyone's attention because we need to make sure that everybody understands what this is. There was some heartache expressed from both sides. Representative on behalf of Angie Gerard and Arthur West himself about our discussion at an open public meeting about this settlement in our previous board meeting. The requirement now is once this settlement is agreed to and signed on our behalf, paragraph 5 identifies that it's entered in good faith to resolve a dispute, mutually agreed to act in good faith to refrain from criticizing or disparaging each other with respect to this lawsuit. So once this agreement gets signed, if this board does agree to approve this settlement agreement as it is, a reminder to all of you that as the Board of Health, once it's signed, we should not be out in the public disparaging either Mr. West or Angie Gerard or her attorney related to this lawsuit. So I would just give you that caveat to try and prevent any potential problems going forward in the future. With that in mind, you've had this settlement agreement. Hopefully you've had a chance to read it. Before I ask you to consider a motion to approve this, I open it up to the board if you have any questions related to the agreement itself or concerns that you see.
Any
All right.
questions or concerns?
Sorry.
Oh, hearing none.
Actually, I have a question.
Yes, Dr. Cleary.
Is there any reciprocity in that agreement to not disparage the other?
That is, it's actually, I required that to be in here as well. So that both sides, parties agree not to criticize or disparage each other with respect to this lawsuit. So yes, they asked for it against us and I required it from them as well. So
thank you.
Yes.
Good question. Thank you. Any further comments or questions?
What does that include? I mean, can you talk about the facts of the case? I mean, what's the definition of disparage?
So what I would say is there's not a confidentiality provision related to this. Obviously, we're an open public meeting in terms of approving this. So in terms of the settlement, et cetera, that's all public knowledge. I think their point is they don't want you to come out and start saying, as Mr. West wanted to have included this, no one should accuse him of being a lawyer falsely. So that would be one. Second, I think disparaging, their concerns were comments that this was a frivolous lawsuit, et cetera. They think that that would be considered as disparaging them as poor attorneys or poor people, et cetera. What I would ask the board is, we have resolved this case now. And I would say, don't go out in public and start saying bad things about Angie Gerard or her attorney or Mr. West related to this lawsuit. Obviously, the opportunity for anybody to make comments about each other in a different forum not related to this lawsuit is fair game. I mean, Commissioner McKinney is involved in a campaign. So to the extent that she should be able to have a free opportunity to discuss Angie Gerard is available. Likewise, Angie Gerard, as a public citizen, has a right to put in written comments to the board if she disagrees with things that we are doing. So it's focused solely on this lawsuit, sort of making bad statements about each other related to this lawsuit. I hope that helps.
Any other questions or comments?
So up until the point that the agreement is signed, we can characterize it as frivolous at this point. And then after the fact, we would not characterize it that way.
Dr. Atterbury, you caught on to my very clear distinction, which is a true statement. And in fact, I will let the board know there were concerns expressed by both the plaintiffs that they had said because you all had disagreed with the lawsuit in the first place, they were thinking of backing out on the agreement. So I'm thankful that that did not happen. And the opportunity for this board at this point in time to make statements, you can. I would just say, let's not waste our time. I think people here have expressed those opinions previously. But in terms of the agreement itself and the provision, which is paragraph 5 of non-disparagement, that only goes into effect once the settlement agreement is in place, because as of now, you as a board have not agreed to this. But I guess I would say, let's just sign it and get this thing over with. Can we do that?
All right, with that, I will ask for a motion.
Go ahead, Dr. Atterbury. I know you're ready.
I can just agree never to mention it again. And I can thoroughly state that I will not mention it again.
Fair enough.
Is that a motion?
I make a motion to approve the settlement agreement related to the number 21-2-00768-39 by Angie Gerard and Arthur West.
Is there a second?
This is Dr. Clary. I'll second.
It's been moved and seconded. Any further comments or questions?
Just a question for Mr. Elliott. Would you prefer the
Abstain, Commissioner Lindy.
abstain?
I would handle this exactly as Commissioner McKinney identified last time. I think the county commissioners, because of your position, should abstain from this vote. So yes.
Thank you for that clarification. All right, I will then ask Mr. Eibach to take a poll.
Okay, if you're in favor of the motion, please state yes. If not, please state no. Commissioner McKinney.
Abstain.
Commissioner Lindy.
Abstain.
Councilmember Byers.
Yes.
Dr. Atterbury.
Abstain.
Councilmember Duval.
Yes.
Dr. Clary.
Yes.
Ms. Algren.
Yes.
Ms. Ackerman.
No.
And Commissioner Anderson.
Abstain.
Okay, the vote is 4-1 with 4 abstentions. 4-1 with 9. That's interesting. We have 9 members, but 4 abstain. Is it voting members? Majority
Yes.
of the voting members? Okay.
Voting members. So where you have 4 abstentions, those are non-votes. So you are
Okay.
a 4-to-1 vote on approval.
Okay. 4-1 in favor.
All right.
Thank you. Thank you all for helping on this. We will have this agreement signed. It will be disseminated back to the plaintiff's counsel regarding it, and then payment will be made from the health district to these 2 individuals in the form and fashion identified at $2,000 per settlement. Thank you.
Thank you, Mr. Elliott. Lots of work. Thank you. All right, we'll move on now. We'll move on now to new business and an update on the Board of Health city representative candidates. Mr. Eibach.
Okay, so both terms for elected representatives expire at the end of this year. Those positions are held by Councilmember Byers and Councilmember Duval. We have advertised those positions over the last month, and we did receive 3 candidates. And those candidates are Patricia Byers from the city of Yakima, Lupita Carrillo from the city of Tieton, and Janice Decio from the city of Yakima. So at this point, they'll be turned over to the Board of County Commissioners, who will continue the process for interviewing and for selection and appointment. Now, also as requested at the last Board of Health meeting, that our staff, Yakima Health District staff and legal representation work with the county legal representation to make sure that they're meeting deadlines. And so we will continue to work with the county as far as moving forward with that process. Any questions on the elected representative positions?
Any questions, comments? Hearing and seeing none, we'll move on then to the proposed adoption of the 2023 fee schedule. Oh, excuse me, I'm reading the wrong line. We'll move on now to the Board of Health citizen representative candidate selection for interviews. Mr. Ryan.
Okay, so we do have one citizen representative position whose term expires at the end of this year. And that position is held by Dr. Cleary. We have advertised that position over the last month. We did receive 4 candidates that are interested in that position. And I remind you that this is a position that represents public health, healthcare, and providers. So these 4 candidates are Deborah Brown, Dr. Sarah Kate, Edie Dibble, and Dr. Douglas Shearer. We do have 4 candidates. In the past, we've narrowed down the candidates to 6 candidates when we had more than 6. So at this point, we have checked with board members to find out availability. We do have a placeholder on October 13th for a special meeting. There are some staff members that are going to be at a conference that day, that week. And so we did check on the 19th and the 20th to see what the availability is. And the 20th seemed to work the best for the most number of board members. So if we would like to continue moving forward with a special meeting on October 20th to interview all 4 candidates, we can. There is that placeholder on the 13th too, which could be, could be under discussion.
Ryan, my only comment or question would be when I indicated that I was available on the 20th, it was for the day. And traditionally we've had our special board meetings in the evening. So I just want to confirm that I am available on the 20th as long as it's during the day.
Okay. And I do remind people that we don't necessarily need all board members there. What we'll do is we make sure that we record all the interviews, and then we give plenty of time for board members to watch those videos so that you can make a decision at the next board meeting on which candidates you would like to choose for the position. It is hard to get 9 people all at the same time.
All right.
So if the 20th works and we want to interview all 4, then there could be a motion for that special meeting on the 20th to interview all 4 candidates.
Is there a motion to meet on the 20th?
Was it your intention, Director Fresco, when you mentioned that Ryan would be talking about this, are we also considering then having a vote or considering to vote an approval or denial of the letter that Councilwoman Byers will be presenting?
Yes, that's what I was anticipating, because we recognized that because we had citizen representatives to interview that we wanted to meet already.
Okay, I'm just making note of that because it would be recognizing what Ryan just stated, that we don't need a quorum necessarily for interview, and we could watch the videos, but it would be important because there would be a vote. So attendance would be something that would be important.
Yes, thank you, Commissioner McKinney. We always strive for a quorum regardless of whether we're making a voting decision, but you're correct. Thank you.
So yes, if we do have add that agenda item on there for that letter, then we would need a quorum, and we would definitely try to find the timing where we have that quorum.
And may I recognize that Councilmember Byers has her hand up?
Yes, thank you very much. I do have another commitment on the 20th from 1 to 4. Do you have a time set for the interviews?
Not yet. They're kind of all over the board on availability.
Okay.
Ryan,
So
one more quick question.
anytime in the morning. Yeah.
If you're going, if we do it on the 20th, then might I just ask that the first order of business could be consideration of the letter, so that could at least potentially make it easy for those to participate for that part who can't make it for the entire time.
Good point. Thank you. Council Byers, do you still have a question or?
Oh, no, I'm sorry. I was just asking about the time because I do have a commitment from 1 to 4, but I'm available all morning. So thank you.
Yes.
So, Brian, will you be sending that out as soon as you have it so that we can all get everything put together?
Yes.
Okay.
Yes, and if I may clarify, actually, this is I'm glad that we're having a conversation with the board. It may end up being that we have to meet twice in one day to accommodate the needs of the candidates.
Yeah.
So we can certainly accommodate, as you said, Commissioner McKinney, the need to have as many people together to vote. So we will essentially have 2 board meetings, I suppose.
Okay.
or a pause, if you will. But
I think
we'll
one
discuss that
pause.
with Mr. Elliott. Thank you.
Yeah. Yeah. All right. Any further comments or questions?
Commissioner Anderson, can I make just a quick point?
Yes.
I noticed that Councilwoman Duvall nor Dr. Cleary have identified themselves as candidates, which I'm sad to see, but I am thankful for their service during this last period of time and all that we've done. So.
Yes, thank you. Good point. Thank you very much.
Thank you for that, Mr. Elliott.
Any comments, Ms. Duvall or Dr. Cleary?
Just a question. When does the legislature reconvene?
Early January.
It reconvenes in January, but it's the sooner we can get the letter out, better, because it'll be in my history of working with legislation, the earlier the better, and the simpler, like a 1-page or 2-page, it stays on top of the stack and it goes around in their pockets.
Do we need to have a motion to change our meetings since we had previously voted to identify when we would have our meetings?
I don't you think we need to, Mr. Elliott, just for the public?
You can, that'd be fine.
I just know that I think we voted and we've predetermined when all of our meetings are.
Yeah.
So.
But if we're calling a special meeting, as long as the advertisement is done to the public consistent with the timeframes, we should be fine. I mean,
You're the boss.
Well,
that's why I'm asking.
Yeah, Ryan's done this on special meetings before, and the timeline's required by the statute. So.
Okay. All right, then we'll forego taking a vote then. And we'll target 20th as we need to have a pause in them, as Mr. Fresco suggested. We'll maybe make those accommodations. All right. All right. Well, the last item on our agenda is
I'm not sure, Commissioner, whether you were asking for Councilwoman Duvall or Dr. Cleary to identify any comments. I wasn't sure if you wanted that to happen or if they wanted to be off the hook. I'm not sure which one it was.
Well, I didn't hear anything, so I just kind of let it go.
We wanted to be off the hook. You got it.
No, I just, want to thank everyone for, I think, the experience. All these meetings have been so informational. Unfortunately, for me, the time of the meeting is difficult to attend. I really do feel like the Board of Health would have more applicants if we had a meeting that was later in the day that worked with people that had working schedules. So just something to think about in the future. I will still be very active and watching your meetings in the future, but at this time, it just doesn't work out for me.
Thank you very much for your service, Dr. Cleary.
I think this was a great experience. My biggest regret is that we were not able to meet in person. I think that would have been a really nice change in the tone of the meetings, and I regret not having had more direct contact with the great staff of the health district. But hopefully, when Zoom meetings become something of the past and we meet in person again, I would definitely consider coming back to the board sometime in the future.
Yay. All right. Thank you both very much. Appreciate it.
I could just piggyback on that. I concur with Dr. Cleary about the idea that, like I mentioned before, Andre, yeah, if we can get back to in-person meetings sometime, I'm all for it.
Well, and we do have the benefit of both board members being with us for a few more months.
All right.
Yeah.
We're grateful for that. Thank you.
All right. Well,
Open to
we
meeting
have
in
one
person
more
as
item
well.
to. I'm sorry. What was that?
I just said I'd be open to meeting personally as well. Thank you.
Yes. We have one more item on our agenda, and that's the 2023 proposed budget. The strategic goal is to deliver the mandate services and board awareness. Is Mr. Porter going to do that?
Yes, I am. thank you for that. And as you said, this is just for presentation right now. Voting hopefully next week or next month in October will be open to eligible to vote on and hopefully approve at that time. So this will be sent out to all the board members. It will be available to the public through our website, and there'll be copies up at the front desk as well. Next page, please. And really, the story is a shift in public health. You're starting to see a shift. First, 4 or 5 years ago, there wasn't a lot of funding for public health. And in fact, not many people knew or care about public health. And to be honest, I didn't know what public health was until I applied for this job. So it's one of those things that has always been in the back of people's minds, or not even thought about before. But as with what's happened with the pandemic, there's definitely been a shift and a focus back to public health. And so what we're seeing is actually more funding that we've had in the past. We've had a lot of funding specific for COVID, but not necessarily for a lot of the other things that we do here. Now we're starting to get that funding. That investment is back into public health is becoming real, which is our springboard more or less into the future. This is a good, strong budget. And a lot of that has to do with the redirection of people's attention. So with our new budget, last year we had 44 FTEs. We are budgeting for 49 FTEs. A lot of this has to do with building our infrastructure with a grants coordinator, with an HR specialist. So a lot of people that are providing direct services, environmental health specialists, community health specialists, public health specialists, and the nurses, they can't do their job effectively without good support, right? They won't be able to do their job effectively if, not having benefits, medical benefits, but understanding their medical benefits, not just having retirement, but also understanding their retirement. If they're happy within their job, they will also be providing good services out to the community, is really what the thought is behind that. Next page, please. I'm really just going to go over the summary of these programs. Could you zoom in slightly, please? It's really hard to see. Again, everybody will have an opportunity to review this. Today, I'm not going to get into the weeds. We've been in this meeting for 2.5 hours. I'm sure you're not all that interested in getting into the weeds. I have, and since then, I have noticed a typo that I will fix before I send out. But so that'll just, one little typo will change slightly. But as you can see here, what I really would like to focus on the moment is foundational public health services. Last year we had 0, and this year we have $2.5 million. And then again on our COVID response, last year we had 14.5 million, and this year we have under $1 million for our COVID response. So you can very well see, I've always said that the general ledger, our financials, tell the story, and this budget is telling a story as well. We're seeing a very real shift from the COVID response to other public health services. Next page, please. So this is, the previous page was a summary, and now this is the detail of what our foundational public health is. And it's just about everything we do here. It's from FPH assessment to communication, partner development, business management, technology, environmental health, and general CD. So this is really shaping us for a springboard into the future with that 2.5 allocated money from us, or from the state, excuse me. And then when you scroll down a little bit, I would just like to review the COVID piece. The next page, please. Yes, the top of the next page is the COVID response. And as you can see, there's been a major shift, major shift from last year's demand for testing and vaccination needs to this year's. Next page, please, is continuing with the programs. Again, I'm not going to get into the weeds. If you do have any questions about that, please reach out. I would love to get into the weeds with you if you would like to do that. I guess the only thing I would ask, please, is if you do have questions, to reach out before the next board meeting so that I could be prepared for those type of questions, or maybe I can answer it in the meantime. Next page, please, is our company-wide income statement. And again, you're seeing the major decrease in federal funding and a major increase in foundational public health funding, which we are directly investing in our employees. You're seeing a 1.1 increase in employees, and that's a direct investment to bolster our workforce here. And a lot of the changes that you'll see, especially the big changes, are directly related to COVID in the expense sections. Next page, please. So with that said, our total entire full budget, our operating budget is 9.6 with an enhanced of 500,000, leaving a 10.1 total budget for 2023.
All right.
Well, thank you. If there's any over large questions, I'd be happy to answer. But otherwise, we'll be reviewing or having a discussion about this next month.
Okay. Any questions for Chase? All right. Hearing none. Our next meeting is going to be a special meeting on the 20th. I think time to be determined yet, our times. We may have to split it or stretch it out. And then our regular general meeting is October 26th. Any further questions or comments?
Commissioner Anderson, I do have a comment on the budget.
Okay.
Just on the timeline, we will be advertising for a public hearing for the budget next week. And then just we ask that board members do review the budget over the next month, ask any questions you have, and there will be an actual decision or the proposed decision for next month. So if you could just be prepared to make a decision on the budget next month.
Okay. Good comments. All right.
Commissioner Anderson, Commissioner
Yes.
Anderson, I'd like to recognize Councilmember Duval, I think has a question or comment. Or maybe her hand was just up.
I'm not seeing it up.
Oh, okay, good. Well, it's gone now. If I may just add one thing to support what Ryan was saying is that, again, we are asking for your consideration of approving our budget at next month's meeting. We don't have a board meeting in November. So our backup to meet in state law would be to approve it in December, but we've historically attempted to approve it in the October meeting. Thank you.
Good comments. Anyone else? All right. Well, hearing none, I will entertain a motion to adjourn.
Motion to adjourn.
Is there a second?
I'll second it.
Then moved and seconded to adjourn. Anybody not in favor, raise your hand. All those in favor say aye.
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 All right. Anyone opposed? We are adjourned. Thank you all very much. Appreciate it.
Thanks, everybody.
Thank you. Have
Thanks,
a
everyone.
wonderful
Thanks,
day.
everybody.
Thank you. Bye-bye.
Bye.